dedicated to empowering you with information
to make positive choices
and be advocates for your overall well-being.
Welcome to The Health View. Welcome to The Health View. I'm Yvonne Dunitz, and this is Dr. Margarita Ochemaya. And today we're going to be talking about the specialty in medicine called endocrinology. And Dr. Ochemaya is an endocrinologist.
Yes.
And an endocrinologist specializes in hormones and the endocrine system. Would you be gracious enough, as we have our dialogue today, to talk about what is the endocrine system?
Well, very importantly, endocrinology is such a large word. It's already a pretty
a
good one in spelling bees.
Yes.
But it is the study of the intercommunicators of your body. So it studies hormones. And what is a hormone? Is a substance by which one organ can communicate with another organ, sometimes as deep as how one cell communicates with another cell. And so truly endocrinology is the study of the internal communication of our body. And that having been said, endocrinology is everywhere in the body. So when we study endocrinology, for example, we study women's health, we study the gonads, we study the ovaries and the testicles and the reproductive system through the means by which the hormones are communicating effectively to create that procreation and the continuation of the human species. Mm-hmm. If we look at it from the adrenal glands are extremely important for energy and metabolism. Without the adrenal glands, we would die. The thyroid gland is another gland that has a lot of hormone communicators, mainly the thyroid hormone. And it happens to be presently a very significant epidemic of thyroid disease in our environment and the patients that we deal with today. Also, another very important topic would be diabetes. So a very well-known hormone is the hormone of insulin. And insulin is very important for sugar metabolism. And very importantly, with people who do not have insulin, they have type 1 diabetes. Or if insulin doesn't work well, it would be type 2 diabetes. So as you see, there's a lot of different applications to the study of the communicators in your body.
So tell us a little bit from a personal point of view why you decided to go into endocrinology, and what does it take in studying and being a doctor to become an endocrinologist?
All right, so two very good questions. Yeah. I am passionate about this because the more I know, the more I realize I gotta keep on learning. And it is a field that is actually, this year, will turn 100 years old. Wow. So in the history of medicine, it's new, all right? New. You know, 100 years aren't that much when it comes to really comparing it to Chinese medicine and other medicines that aren't Western. But most importantly, why I became was I originally started wanting to be an OBGYN.
Really?
I did. I was fascinated by babies and the concept of pregnancy. Sure. And therefore, one of my strong specialties within endocrinology is fertility and infertility, for that matter. But as I started in my OBGYN quest, I realized that working as an OBGYN was going to be very complicated for me because it was quite a long time ago. Yeah. And we didn't have that group practice ability, so I really always was very much founded on the doctor-patient relationship, and I wanted to be there for all the mothers I cared for. Sure. And that means I could never take vacation. Never. Or even consider a family of my own.
7, right?
Yes, the old school OBGYN definitely was community, solid state.
My grandfather was an OBGYN. And my mother, I remember saying to me, never marry an OBGYN. I never saw my father.
They're never home.
Never home. He was constantly out, constantly out.
And that's a big deal now when you're a woman and trying to understand, as women have entered into the medical workforce, that home balance and how that took place. So it gave me some thinking about what I really wanted in terms of maintaining my balance as a
Quality of
woman,
life.
as a mother, and then, of course, being very satisfied by my profession. Then I went into cardiology. So I was fascinated by the heart. I loved running codes. I actually thought of them as a very spiritual opportunity to have a conversation with God. And that, too, in the field I was in the mid-90s, was more about cardiac catheterization and the interventional cardiologist, and I really didn't want to be that. So I was, again, kind of poised into where would I really fit in that would fit with me.
Sure.
And endocrinology just fit perfectly because I could address my fertility desire, nothing more rewarding than helping somebody who has been having trouble getting pregnant, helping them do that naturally.
Surely.
And also, very important understanding that women and men are different. And so the gender differences in the forms of the communicators and the hormones are extremely a topic that is of continued interest to me.
Sure. So tell me, you went to medical school where?
Okay, so I'm originally from Colombia, South America.
Beautiful.
Yes, and truly as a little girl, I came to Philadelphia, and my parents were going to school in Philadelphia, and we did a trip to Harvard. And I think I could visualize, help you visualize this. I felt like the Monsters University. When I thought, it's like, I am going to be a big scarer.
Yeah.
And then on that note, clearly I'm not really good at the fear medicine, I'm not really good at scaring people into doing things. So endocrinology also provides me a tool to develop that doctor-patient relationship and enable my patients to be their own caregivers. And so with something so complex, being able to translate it into something that is understandable and that a person can relate and then say, oh yeah, I understand, that's why I have that. And therefore now, I truly think I'm a salesperson for health.
Isn't that interesting? So you went through your 4 years of medical school.
Yes.
And then you go through residency. And in residency, did you specialize at that time in internal medicine and then go on to
That's wonderful.
endocrinology?
Well, it's a little longer than that. So I
Okay.
started in Colombia,
Okay.
and I won an honorary exchange student. So I came to BU as an exchange last year medical school student.
How exciting.
And I was offered a place outside the match to enter internal medicine. So I did it at Boston City Hospital.
Great opportunity.
Back in the time.
Sure.
But now it's Boston
experience.
Medical.
Sure.
Oh, it was a fascinating
Huge
experience.
place to get experience.
Yes. So I do have my MD degree from Columbia.
Okay.
But I was privileged, I was so honored with this exchange program to then come to the United States and then learn the system here. And then was privileged again and honored to be offered this position. I did internal medicine for 3 years. So my medical school in Columbia is 6 years, not 4.
Oh, wow.
And then we did 3 years of residency, and that was where I did my internal medicine.
In Columbia or now
At
in
Boston Medical.
Okay, so in
Boston City, Boston Medical.
Okay.
During the time I was there, the transition happened.
Okay.
I'm board certified in internal medicine.
Okay.
So in that time, this was in the early 90s, you could decide if you wanted to be primary care tract or full internal medicine. And you did full internal medicine if you wanted to then do another subspecialty. So if we're keeping the math, we have 6, then 3,
Yeah.
and then another 3 for endocrinology. I had ample opportunities to stay at BU, but I chose the Brigham and Women's Hospital and their endocrine and hypertension division.
Okay.
So now the reason why I chose the hospital is because there's a great number of births, and they do take care of a lot of pregnant ladies there.
Yeah.
And then the endocrine hypertension, that also suited me perfectly because I love the cardiovascular system and the differences in females and cardiovascular disease where we get hit a little harder. They've done experiments on if they sample exact same occlusion in a male animal specimen versus a female animal specimen, the female heart is usually smaller and a little thin in the walls, so the heart attack is much bigger.
Sure.
So that too started creating an unbelievable amount of questions for me. And in the endocrine hypertension division, I won an award because we did gender differentiation in the way heart attacks happen. And we looked at how actually different medications help men and women differently. So that was extremely interesting because that, again, now we're in the late 90s and we're introducing more women in clinical research. So that also is something I'm very passionate about because, you know, we're different. Men and women are different. And in our differences, we benefit with each other.
So when you were done with all that training, so it's 12 years of training.
I was offered to stay on board as a clinical instructor, but by this time, I had become pregnant.
So you started your own family.
I had a very hard decision. It was extremely difficult for me because I think that really we can go back to really what my belief of what a doctor is.
Yeah.
And a doctor is a teacher, foremost. I think it's the Latin translation.
Of course it is. Yeah.
And then we add the fact that it's a community. A doctor is an educator for the community.
Exactly.
And so all these passionate things that drive me, which are being involved with the community, which are being involved with teaching, with also empowering my patients to get better and not just be subject to taking prescription medications and not realize why they're taking them, for example, or what can they do about it, or how can they progress within their field of their condition. And so very interested in understanding the difference between being ill and being healthy, and that little gap in between that can be saying, well, you're on your way to become diabetic. Let's just make some changes. And that is afforded by that educational component.
You know what's interesting, being a woman, and as you said, being a female doctor is different than a male doctor, and you were at a bridge in your career related to being blessed by your own children. But going into endocrinology, being a woman probably gives you, in a sense, a leg up too, related to you know, hormones and understanding what your own body has been through and your own process of aging and going through different experiences, so that you can probably relate very much through the different things that go on for females as well as men.
Right, and I think very importantly, you know, we had more male doctors and we're seeing actually quite the difference. Now we're seeing even more female doctors entering into the medical field. But it is true that I have a certain degree of empathy with regards to understanding the process of, for example, infertility or the process of breast pain. You know, when I myself have understood this or have had questions, I think I can relate better with another woman with regards to that. And for that matter, it already naturally happens to be that I have more women patients than male patients.
So how does it work related to the medical profession as a whole regarding when someone actually sees an endocrinologist? When do they tap you for your specialty versus if you're in internal medicine? Would there be things that you'd automatically take care of and then refer to an endocrinologist? You have the combination of internal medicine and endocrinology.
Right.
So that makes you different in that sense with more skills.
Well, and to the degree is it's more like I'm just a little bit, I've devoted 3 more years of training, and I am so fortunate and I am so thankful for the opportunities I've had with the teachers and mentors I've had through my life. But in understanding these topics with a little bit more detail, with a little bit more hyper-focus. So an internal medicine doctor can easily understand hypothyroidism, but then the deeper levels, the more of the root of the cause, or kind of trying to understand how it really begins, and then being able to convey it to my patient without it being so complicated. Endocrinology, by far, is one of the hardest subspecialties within internal medicine.
So can a patient self-refer, or do they need to be referred by their primary care provider?
That's a wonderful question because it all depends. We are now going through a great change in our insurance issues.
Sure.
And so let's say if there was no insurance at all, you can self-refer. But usually what happened in the late 90s is we were seeing a lot of subspecialties and it was being overused a bit. And so they instituted the primary care system to be able to say, okay, you need a referral because after what I've considered is your condition, you've reached the point where I need a team player to work with me to then work with you. So it's usually in layers, and sometimes driven by the severity of the problem, and sometimes related more if you have the ability to self-go to anywhere. That would be, for example, a PPO insurance program.
Sure.
An HMO, you really always have to go down through that centralized system where your primary does or does not give you a referral.
Because of your combination of internal medicine and endocrinology, could you in fact become someone's primary care provider?
As a matter of fact, that's how I started. When I then, by virtue of being pregnant and decided with my husband to move to the suburbs, I started in a private practice where we were called primary care specialists. So we were all primary care, but then we all had one specialty. We had a rheumatologist, we had a cardiologist, we had a pulmonologist, and so we were both primaries and specialists. And it worked really nice, but what happens with endocrinology is sometimes the condition, for example, like diabetes, would require more frequent visits. So then they would say, well, can you be my primary too? And what would that add is that I would also do their pap smears and their preventive care. And if they had a cold, they would come and see me for the cold as well as for their diabetes. That worked well in the environment that we had. What was difficult was that if you have referrals, and they were like, well, why are you taking my patient away? Or so it was by choice. But ultimately, over time, I decided to be specifically endo and be a partner with my referring provider to both then have dialogue on the case. And then, for example, by communication, she would know what the plan was going on. And so we would work together on that. But it is a sensitive topic because if you're seeing your primary once a year and you're seeing your endocrinologist 3 times a year, it's kind of like, well, why don't you do both? But I tend to think that, for the more basic visits, for the strep throat and those things, those are more basic. You can be taken care of, and it doesn't have to be the endocrinologist.
So in an emergency, so then what I'm hearing you're saying, there's a primary care provider and then there's a specialty of endocrinology. So if there was an emergency or something with someone's health care, they would go to their primary care provider because you're
Right.
specializing in endocrinology.
Right.
And now that whole thing of as far as primary care providers is changing now too, because now hospitals have hospitalists.
Right, and that was a big change
A
because
huge change.
once, for example, a patient of mine would have, yes, let's say a diabetic emergency.
Yes.
When they go to the hospital, they're taken care of by the hospitalist. And then they could consider an endocrine consult or not. But it came out of the fact that if the doctor's in the practice seeing patients, sometimes it delayed the discharge
Right.
if they didn't get the consult in time.
Surely.
And so it's just organizational and multi-group. And so sometimes you were rounding, sometimes you're in the office. And now when you're in a multi-group specialty, you cross cover with your patients.
Yeah.
So for example, if you and I are both endocrinologists,
Yes.
I'm on call, I'm at the hospital all day, but my patient has a problem, they would see you.
Got it.
So that's some systems work like that.
Surely. And you have really kind of paved the way in the sense that you have your own practice,
Correct.
which is huge as far as your own independent practice where you have your specialty and there you are and doing all these wonderful things there. If you were to do it again and go into endocrinology, would you do it again?
That 1,000 times over.
Really?
Yes, I
So
love
what
it.
is the part that you love the most?
My patient.
Your
Because endocrinology, and for example, in dealing with diabetes,
Yes.
it is a condition that I can't say it's incurable, but it is a chronic condition. This isn't like when you get a strep throat or pneumonia and you get better
Right.
and everything's fine. This is something that we need to deal with for a good amount of time. And so we develop relationships. You understand sometimes that, if they're going through a bad time, their health might be worse. They're not taking as good care as they would otherwise. And so ultimately what we want is to develop that kind of relationship over time. And there's nothing more rewarding than to see somebody who comes in sick and burdened and maybe even tired about their condition. They don't want to deal with it at all. To be able to befriend it and see it as another part of life and deal with it in a better way. There's a lot of psychology in endocrinology.
And in endocrinology, you also approach it from the mind-body-spirit approach by the basis of what you believe is good medicine, correct?
Right, and that ties in perfectly as to why I'm independent. I usually think that because of the depths of the conversations we need to have, I was being really short in time to be able to spend the time I needed with my patients. And so I wasn't really going to be changing the system anytime soon. And so I thought that being independent, as much as I did take a good financial change for me,
Surely.
it gave me an unbelievable rekindling with my relationship. So now I have a 1-hour appointment for every patient.
Okay.
So we talk about, you know, all the way from how your diet is to your exercise and how you're moving and being able to be more flexible, so your biomechanical aspects, to then your mood, how is your stress, and that's because the adrenal glands totally are involved in the stress environment, not just mental but physical. Sleep.
Right.
Sleep medicine is about maybe 20 to 30 years old.
Yes.
You know, back in the time, we just thought when you went to sleep, the body kind of shut down. And if anything, the brain's when it really wakes up. And a lot of regeneration and hormones go into play with sleep. So the importance of sleep, as we've talked in a couple of our previous
Absolutely,
shows.
yes.
And then, as I talked mood, now we're talking a little bit about how the environment is changing our food industry.
Yes.
And what is an apple today is not what was an apple 40, 50 years ago.
Absolutely.
And so we definitely, if you're going to be talking about a diet, you really need to have some good foundational knowledge on nutrition.
Now, speaking about a diet, when you think about even the growth hormones that are being given to the cattle and to other, how did you see that affect your patients related to their own hormones?
Well, extremely important. We have also, I think we have one show that we might be discussing the hormone or the gender bender hormones.
Yes.
And in medical term, it's called endocrine disruptors.
Yes.
And it's what it is. It's disrupting the endocrine system. So it's kind of in this communication, like our conversation right now,
Yes.
it would be like if the TV all of a sudden got grainy and or the cell phone, and all of a sudden that connection isn't going very well. Pesticides, herbicides, petrochemicals, plastics, and flame retardants all behave like estrogen.
Yes.
And
interesting, like estrogen,
like
which does
estrogen.
what to the body?
Estrogen is meant to help either one, grow tissues, mainly grow the inner lining of the uterus in women. In men, they would actually interfere with their testosterone production. So what we're seeing now is women are having symptoms of male-like issues, such as hair loss and weight gain in their abdomen and facial hair. And men, you know, they're having a little bit more growth of their breasts.
Yes.
And more hair loss. And so there's a lot of subtleties in this whole situation, but at the same time, clearly the environment is having a key role in the endocrine system. And in the upcoming Endocrine Society meeting that we're celebrating 100 years, there's going to be a full symposia dedicated to these disrupting chemicals.
Amazing.
Yeah, it is amazing.
So
and concerning for that matter, because that
Absolutely.
brings up supplements, because you know, there's a big debate about supplements. You know, it's a very lucrative business. It's $1 million industry. And some people say, you know, they're not really good. Some people say, you know, they're the best. And I think ultimately, and I know you'll be having a show about that, is really sourcing those supplements well. But the most important one I'd like to talk about is vitamin B. B is extremely important for all cellular metabolism and the division of cells, and very important for brain function. And one of the topics in endocrinology is neuroendocrinology, and the chemicals and the hormones, which in the brain are called neurotransmitters, they are affected by all of this. And that will correlate as we are seeing higher and higher rates of dementia.
Now, you mentioned vitamin B. Now, they tell you vitamin B12. What's the difference? Vitamin B versus vitamin B12? Are you saying this is a vitamin or a supplement that is good for the brain or
yes,
for your endocrine?
and that we as physicians need to really involve ourselves in knowing what our patients are taking. because it could easily have been on a shelf for 10 years. It could easily be tainted. It could easily be chalk. So if we totally take a blind eye, that's probably not a good idea, because they can even be poisoning themselves. And at the same time, if you are too much into it, you want to think of other things that we could promote, such as food or real substances. But supplementation has a role, definite role in understanding that. And how do I work with that is that we measure. We measure the micronutrient levels.
Through blood.
Through blood. And so as we measure the micronutrient through blood with a well-scientific-based laboratory, we're able to tell someone, listen, you have low vitamin B. Now, your question about vitamin B versus B6, a vitamin is an essential nutrient that we cannot produce. So we cannot live if we don't have vitamins.
Right.
And we can create a significant disease from lack of them.
And we can get them through food or as through supplement.
Absolutely. And ideally, it would be through food.
Right.
Start there and no more. But unfortunately, may it be by our lifestyle, maybe by industrialized farming, maybe by our choices, and ultimately sometimes absorption issues within how we absorb these supplements or our food, we have deficiencies.
What would be a good food that has vitamin B in it?
Actually, eggs. Anything that comes from an animal source. Bees. So that's a very big point for anybody who's a vegetarian or particularly even a vegan, because they will have high risk for vitamin B deficiencies.
So it would show up low.
It would show up low. But then again, what test, right? And so again, there's a little bit more knowledge and depth into how to order these tests, how to interpret these tests, a little bit of understanding of what their diet is after a prolonged conversation and history evaluation. Maybe they have food journals. And so you start identifying that. And then lastly, with complaints. If they have tingling in their hands and feet, if they have issues where they feel creepy crawlies, they could easily be vitamin B deficiencies. And B is many, there's B1, B6, B12. Another one that is good to discuss, and we'll go on further, but vitamin D. We are here in New England, and vitamin D is the counter hormone for melatonin.
Yes.
So the vitamin D is like the light vitamin.
Right.
And so we do not have that much vitamin D. We need to have at least 60% of our body exposed to temperature higher than 70 degrees for at least 3 hours in not direct sunlight. That does not happen in New England.
No, it doesn't.
So almost all of us are vitamin D deficient. The problem we have is that it's a fat-soluble vitamin, and you can get an overdose of vitamin D. So how do we work with that? We measure the levels on a regular basis.
So are there different ways of measuring blood and blood tests? And is there different knowledge and skills that medical providers have related to understanding how to interpret those results?
Yes, absolutely. So, first is understanding the other labs out there, finding what they do. So could it be when we see blood, it's really what makes blood red is the erythrocyte, the red cell, hence red, which is carrying iron and oxygen. But when you give your blood, it gets through a centrifuge and it spins and spins around and separates those red cells. And then the liquid in which they're swimming is about a yellowish color, and that's called the serum. That also can be separated into plasma. So we can look at it into the red cells, we can look at them in the serum, we can look at it in the plasma. We can do urine tests. We measure in the urine. We can do hair analysis. We can do white blood cell evaluation. So again, that's a whole field in terms of how to measure, what to measure, and then truly there needs to be a good fundamental training to really understand what is good and what is not so good, or what would be more accurate, and that you can rely on the results with certainty.
So interesting enough, a person goes through medical school and whatever training that they have. Are there some medical providers that have more astuteness, education, and awareness on interpretation of blood tests than others?
I think we're all in the same boat. I think we're all driven by kind of what was passionate. For example, internal medicine relies heavily on laboratory evaluations. Endocrinology is more than ever. We really want to understand the methodology, how did they do the blood work, what was the mechanism of which the result was attained, and then if they have any kind of random variation. So sometimes we look at that, for example, I'll bring it to like our viewers, where when you prick your finger stick,
Sure.
and you're pricking your finger stick, if you have to, because you have diabetes, you prick it, and it gives you a reading, 110. You prick it again, it gives you a reading, 98. You prick it again, 115. So there's, within the same person,
Right, there are
just by virtue,
variations.
there's variations. And so the variations can be within an acceptable range or not. You know, where we're like, you know what, this test isn't reliable because every time I test it, it gives me a different number. Whereas when you see finger stick evaluation, they tell you it's up to a 20% variability index. So as usual, what we do is we do trend analysis. I don't really practice medicine as by the numbers, because laboratory tests, I look at like when you're watching a movie and you put it on pause, it's a snapshot of where you were that given time in your given perspective. So it's a continuum rather than, but it's good to get little snapshots across the time to see where you are, if you're doing better, if you're not. But I wouldn't really do just one test and never do it again.
Right.
You know, unless there are some conditions that do require that. Either you are or you don't, you do have or you don't have. But in terms of monitoring, it's always trend analysis, not rather than absolute interpretation.
Now, in your practice, you also have some specialty equipment, do you not?
I
remember you
do.
saying you were so
I
excited
do.
about, what do you have?
So again, one of the glands that is part of endocrinology is the thyroid gland, which is located in the neck area underneath the Adam's apple. Now, women do not have a very prominent Adam's apple, but it's right there. Now, the thyroid gland can have problems. So one is to prevent the problem, and two is once you have it, is it going to be hyperthyroid or hypothyroid? And that's the lab test.
And what's the difference of that?
The difference would be how the patient presents. So usually hyperthyroidism is somebody who comes and has jittery, anxiety, their eyes are wide open, their heart rate is palpitating. They don't need a coat even if it's 20 degrees below zero, because their generators and their energy and their metabolism is way revved up. Right. And then they feel very, very sick and usually lost 20, 30 pounds, you know, and so that's hyperthyroidism, to the point that sometimes it has been confused with somebody being manic. And also they can actually have a critical case where they can die because their heart might just, I mean, if the heart rate is 130 beats per minute in our small little hearts, I mean, we can get cardiomyopathy because of it. The other way around is like, now you're just all flat and exhausted, constipated, the skin is really dry, your hair is falling. Both are associated with the growth of the thyroid gland and tenderness, sometimes even heat. So first comes the patient with complaints.
Yes.
And then with the laboratory tests and the evaluation and the doctor's clinical decision making, then we can decide on what the condition is. And then the machine comes into play because we use it, one, to measure, you know, the thyroid gland. Two, some people might be neither hot or cold, but on the other hand, develop a nodule. Or they have like a little pea size or sometimes a large mass, and that could be thyroid cancer. So in our office, we have purchased our ultrasound machine, and we can also do the biopsies in the office as well.
That's fantastic.
It is.
So it makes it much more convenient for the
Convenient,
patient, and then they
streamlined.
get the information.
And depending on the
feedback.
results, we go a step further. We have the ability to do gene expression classification.
Now, what does that mean?
What happens is that when you take tissue from anything that potentially could have tumor, you'll have three kinds of results. You either have a tumor or you don't have a tumor. But there's a gray zone in between that looks like it's a tumor, but we can't really tell. And so the majority of those that are in the gray zone end up having surgery anyway. But we were doing a lot of unnecessary surgeries. So the gene expression classification is done by Veracyte. It's a company in California that measures the genetic expression of that cell And rather than telling you you have cancer, it tells you with 100% certainty that there are no cancer cells. So when you get told, look, this was an equivocal kind of result, but once we did this additional test, we can tell you with 100% certainty this isn't cancer, and then of course you don't have to have surgery.
Now, if a person needed surgery, what would your role be in that regard once you've determined that there is a need for it?
So I communicate with a surgeon, and I usually communicate with surgeons that specialize in thyroid surgery.
Okay.
Because there's a lot of vital nerves that go through the thyroid, and behind the thyroid are 4 glands called the parathyroid glands. And so we want to make sure we preserve those. So it's microdissection. And so we then refer to the surgeon. The surgeon then takes out the thyroid, and then they're referred back to me for the management and the adjustment of the thyroid dose medication replacement dosage.
And in southern New Hampshire and the state of New Hampshire, do we have specialists like that, or do people need to go into the Boston area?
It all depends. So we have specialists that don't specifically, because it's not that common as much as in my practice it is. You know, so usually we use either a vascular surgeon or a general surgeon who has ample expertise and experience, or we do go to Boston or to Lebanon.
Oh, very good. Okay, so you have that variety. We're very fortunate to have all those close by, aren't we?
Yes.
So in looking about other types of focus within your patient base, of the types of diseases that an endocrinologist sees, what else do you see? Like you were just saying, the thyroid, you see a lot of. Are there other types of things that you see a lot of in your practice?
Okay, well, we'll start, like I usually start like in a methodic way.
Yes.
So most importantly, behind the third eye here, or right
Yes.
between the 2 eyes,
Yep.
in the middle of our head is a gland called the pituitary gland.
Yeah.
And within the pituitary gland, we call her the master gland.
Yes.
Because in the pituitary, above it is the hypothalamus, another brain structure. But the pituitary gland can have some tumors. So that's called neuroendocrine. The most common problem in the pituitary gland would be prolactinoma.
What causes that?
Prolactinoma is a situation where you start producing breast milk, but you're not, postpartum, or you have not delivered a baby. And that is caused by a cancer, a cell in the prolactin growing areas, which start producing prolactin significantly. And that, fortunately, does not need surgery most of the times. Of course, in medicine, there's never 100%.
Right.
Even though I did say about the verocyte because they got the genes. But on the other hand, in this case, we can give medication and control and shrink it and monitor it. So prolactinoma, a very common one. Growth hormone issues such as acromegaly. So people who actually become really, really big.
Right.
Now in adults, since they've already reached their adult height, what happens is you start having very big hands, very big kind of tissues, a very big nose, the jaw continues to grow, the bone over the eyebrows continues to grow, and so you see the person change over time. And unfortunately, with this condition, it takes about 10 years between you start having the problem and then when you get diagnosed, because it's such a slow changing. So they usually present with either severe headaches, diabetes, or a lot of joint issues because they have really big hands and feet, and that's acromegaly. Then we can go on other ones called Cushing's disease,
Yes.
and that's that the pituitary gland is producing too much stimulus for the adrenal to produce cortisol, which is a hormone that produces growth and also modulates our immune system. So Cushing's disease is another one that sometimes is confused with obesity because they just start growing and getting bigger. One of the hallmarks of that is if you have very prominent red stretch marks and rapid gain, or a gain that you wouldn't really otherwise explain. But the red stretch marks are very, very saying in terms of at least to look up and do the workup. And coming down, we have the thyroid, we discussed.
Yes.
We have issues with the prolactinoma, which would be abnormal breast production,
Yes.
but it's due because of the the pituitary. We have the GI tract.
Yes.
The gastrointestinal tract, more than ever now in the field of weight management, we see hormones and how they communicate from the GI tract to tell us that we are full, all the way to telling us that we're hungry, all the way to telling us, like, you just ate, maybe you need to go to the restroom. So there's hormones to communicate all through the different pathways, all the way from choosing our food, appetite stimulation, to digestion, to the ability to absorb our food properly, and then, of course, elimination. Another one is the ovaries. You know, polycystic ovarian syndrome. We see that often in women who have irregular periods. But, you know, some people might just say, well, this is in my family. We all have irregular periods. But it's usually associated with abnormal weight gain, abnormal or excess facial hair, acne. And then sometimes they come to us for weight management. Sometimes they come to us because they have extra hair. Sometimes they come because they have a lot of hair loss. And then the other ones more would be related to infertility. So a lot of infertility is caused by a hormonal imbalance. So rather than pushing, you know, ovulation drugs, I tend to stimulate more the foundational health of the woman and the men. More like what are they eating? How are they eating? Could we change some balance of your hormones by virtue of eating things that contain less estrogen? For example, as we were saying, animals are being fed hormones.
Yes, they are.
Most likely estrogen, and because we don't eat roosters, we eat hens.
Right.
And one of our major protein sources in our diet is chicken.
Right.
But there are a lot of estrogen. Milk is from a cow that just delivered.
Right.
So that too is a hormone. It has full of hormones and mostly estrogen. And so when we're trying to see that, we're saying back off a little bit. Let's look at how we can clean our diet a little bit more.
Let's take milk and cleaning that diet a little bit more. If you know that there may be in regular milk more estrogen, are there other types of milk that one could buy that one would know that there isn't any estrogen in? That would be your organic milk?
Yes, well, we can go all the way to raw milk.
Raw milk.
But, you know, access to raw milk, and then the issues around raw milk is that it would go bad easy,
Right.
and then they might have bacteria, or the pasteurization process is very important, and we've been pasteurizing milk for last 75 years, 100 years. So on one end, the factor of the raw milk to the factor of the cows, we have genetically modified cows to produce more milk.
Right.
But the casein in that milk is very allergenic.
Yes.
And it creates an allergy within the bowels. Some people can determine a milk allergy because they'll have bloating and they'll have some gas and issues with that, but others might not. Actually, a milk allergy could be acne.
Yes.
You know?
Yep.
And so to some degrees, milk is just that they're making it thicker with substances and they're making them whiter. So some substances to make them more appealing in the industrialized farming are the ones that are more to blame than, I would say, if we were using a paleo diet and we were back into having our own farms and our own cows.
Yes.
Which is far from the reality right now.
Is,
but we can use almond milk,
Yes.
cashew milk, coconut milk.
Is there a difference on the different types of almond milk or cashew milk that are good for you versus others?
Well, of course, they too can be tainted with some things. So I go from the spectrum of where you're sourcing.
Yes.
And, you know, doing a little extra research as to which company you like better, all the way to making your own almond milk, which is soaking your almonds overnight.
Right.
And then just throwing that soak milk water out, and then just blending them, and there's your almond milk.
Right.
Same goes with cashews.
Yep.
Raw cashews, unsalted, soak them overnight, and then blend them, and there's your milk.
Right.
So I think it's a misnomer. A lot of people, when you say almond milk, well, it really isn't milk.
Right.
It just looks like milk because it's whitish.
Yes. Hi. So now, have we gone down all the way?
Well, we were going down, and we
We
were
stopped
in
at the
ovaries.
Yep.
Ovaries, polycystic ovarian syndrome, we have infertility, we have problems with blood pressure during pregnancy, and then we also have postpartum depression and postpartum thyroid problems. So again, all related to these rapid and high levels of hormones changing in our body and how they affect us. And in men, we have low testosterone, and we call it andropause. Like in women, menopause, which is different. Andropause in men is a gradual decline in their testosterone levels. In women, when we go through menopause, it's within, I would say, give it 5 years for perimenopause. So really, we suffer quite not so well those 5 years because you still could be cycling,
Yes.
but you can have a lot of abnormal bleeding, the imbalance between estrogen and progesterone off.
Yep.
Then when the period finally, or not so finally, then does not come back,
Yes.
then we have issues with hormone withdrawals, the hot flashes, the night sweats, the mood changes. That can be very debilitating for a woman.
It can be.
And then thereafter, menopause, I call it phase 3. It's more about longevity. It's more about our womanhood. Some related to libido, some related more to missing, you know, those vital hormones to be part of the skin, the hair, and then more importantly, heart health and bone health. Estrogen protects our bones. And once we go through menopause, we're at very high risk for osteoporosis, which is another condition endocrinologists talk about.
Interesting. And now there's been some advice out there for women who are taking calcium to help them with the bones that it perhaps is not needed in the way that we thought.
Right.
What are your thoughts on that?
Well, what happened with that was that we were really, you know, recommending calcium. Your bones aren't good, let's take calcium.
Yeah.
But what we had kind of not really gotten into the conversation was that calcium is not absorbed when you don't have vitamin D.
Right.
So I think, if anything, I'm more talking about optimal levels of vitamin D, and not just within the range, but optimal levels of vitamin D and a healthy diet, you will absorb the healthy calcium.
What would optimal levels be?
Interesting, great point. When you see a laboratory value, it usually gets the name of the laboratory, your result, and then the range.
Right.
The range is a mathematical algorithm of what is the average or the mean, and then 2 standard deviations above and below. And so the range for us in New England is between 30 and 100, but the ideal is greater than 60. So number one, a lot of people who have malabsorption situations, I've seen a lady who had been working the night shift for 20 years. Her vitamin D was undetectable because she never really was outside.
Right.
We have others who have celiac
Yes.
and malabsorption situations. Vitamin D is in the teens.
And celiac, just so that our audience knows, is what?
Celiac is an autoimmune attack against the barrier that absorbs your nutrients in the small intestine. So in this regard, malabsorption is the consequence of this allergic reaction and destruction of the lining. But interestingly, as much as people might just talk about, well, you know, we over talk about gluten, the situation is this, and how I explain it to my patients. If I wash my hands with bleach every time I saw a patient, my hands would not be very well.
No.
You know, because they would be caustic.
Right.
It would cause very much dryness to that. And so when I actually talk about the barrier, refined sugar, what is it refined with? Bleach. That's what makes it white. Flour, how is it refined with? What makes it white? Bleach. So I use that bleach with a punt, but it's because these refined processes create very acidic and caustic food that our mucous membrane cannot tolerate very well. And so eventually, over time, they get like a sunburn.
Yes.
And as the sunburn happens, we kind of peel off the skin, and then malabsorption ensues. So we're always working on rehabilitating your gut, which brings up the point of the balance of good bacteria and bad bacteria,
Yes.
and ties it up to industrialized farming, because as they get given antibiotics, these more superbugs are more available to our gut. And so we start having an overgrowth of the bad bugs.
Yes.
So I always call it like military warfare. We need the good over the bad.
Right.
It's like Star Wars.
Right.
But good bugs overall would be better.
So we've just covered the whole body now. I think
Yeah.
we've covered everything that relates to endocrinology and the things that you do. Now, I know you have something exciting about to happen, and that is regarding your book coming out.
I know.
So let's tell the audience a little bit about your book. What's the name of your book?
So the name of my book is called The Link,
The Link,
The Hormone Link.
the hormone link.
And it's because I see a lot of commercials, something I don't necessarily like, because, you know, engaging the patient into the choices of medications or what to take or not to take, or even the use of Dr. Google, which I mean, I can't stop it. 70% of our population will
It's
look up
using
their
Google.
condition
Yes. Yep.
in Dr. Google. So when you start seeing these commercials, they talk about low T, for example,
Right.
and it's get a pill.
Right.
Or bioidentical hormone replacement, get the hormones.
Mm-hmm.
And really what we have to look back is it right for you?
Right.
Because what is right for your best friend, and even sometimes what is right for your sister or your brother, is not necessarily what is right for you.
Mm-hmm.
And so that doctor-patient relationship is extremely important. So the first part of my book, I talk about the importance of having a good, solid relationship with your doctor. Being able to talk to him or her about, yes, the supplements that you take, other things that you might not be proud of that you do, and then being able to discuss openly that you do go to McDonald's twice a week, or you have your Twinkies, or you do smoke, without that fear of judgment. Because there's a lot of patients that do not tell the whole truth for various reasons. So once you have that solid, trusting relationship, then you can help the person better, because then you really see the whole picture. And then trying to explain each individual organ, as we're talking in endocrinology, in a method which comes from a person that has done the field research. I am board certified in internal medicine and endocrinology. And so trying to explain that is not so easy, because it's very, very hard.
Of course.
But in my book, I try to make it so, for example, we start with a questionnaire, and it'll tell you, well, you seem to have a little problem, you answered a little bit more issues here, and then this chapter might be good for you, so let's keep on reading. And or if you pass the questionnaire, you might have it more as a reference for somebody who might say, oh, I have a thyroid condition. There's a thyroid chapter. There's a reproduction chapter. There's a chapter on male andropause. So I try to just bring it, my 2 cents into the equation. It's geared for patients and or like people who are interested in the endocrine system. So it could also be wonderful for nurses, nurse practitioners, and my other fellow colleagues that might want to get a little bit more of a personal conversation about endocrinology, because clearly my book is not a textbook. You know, it's more like my interpretation of it.
And how will people be able to purchase it?
Well, we're going through the major outlets. You know, it will be Amazon, Barnes & Noble. They can also order it electronically.
Good. So I'm sure there'll be an announcement on a book signing and things
Yes,
where people
very
can
excited
be able to
about
do
that.
And will you have it on your website?
We will have it on our website, and then our second phase, we will also have it in Spanish.
Excellent.
Yes.
That is excellent. So let's let our audience know the ways that they can contact you and learn more about what you provide for patient care in our community, in our area. So is there a phone number that people can contact you at?
Yes, so advancedhealthnh.com is
Okay.
our website.
advancedhealthnh.com.
Correct.
Okay.
And then our telephone number is 603-606-1611.
Let's say that again.
603-606-1611.
And what would be the reason that they may want to call an endocrinologist related to symptoms that they may be having or concerns that they may have? Let's just highlight that.
So first, I rely heavily on my colleagues, because then they know what I do. And when a patient's asking them, well, what do I do now? I have a good ample sources for referrals. There are those that then self-refer, would be more, sometimes they find me on the internet.
Yeah.
But it would be more related to women's health issues, starting all the way from irregular periods to cysts in your ovaries, to problems with fertility, and or trying to do contraception in a different way than just using oral contraception. And then lastly, you know, once they're pregnant, I can help them with their diabetes during pregnancy or hypertension during pregnancy. Usually that is also done with a high-risk OB. So usually we kind of have more like a consultant role rather than a full-on doctoring role. Postpartum depression could easily be a thyroid condition. And then menopause, when it's sometimes very crippling, we help those ladies as well. When it comes to men, it's the balance between testosterone and estrogen and finding the ideal way for them to handle that. I definitely pretty much always refer to the urologist first to make sure there's no mechanical abnormalities. And so usually we work in tandem. With regards to weight, weight is my specialty. I absolutely love helping people prevent getting to become diabetic. So we start at the prevention of diabetes by addressing weight.
Do you deal with children related to that? Because we're seeing more and more children that are...
We do.
Yeah,
I started at the age of 13 because I'm not a pediatric
Not a problem, but
endocrinologist.
that's good for people to know.
Right, so the age, I do have a limitation of 13 and above.
Okay.
And then osteoporosis too. We address osteoporosis. Even though once a person has osteoporosis, it's more to prevent it getting worse.
Okay.
You know?
So if anybody had any questions or would like further information about endocrinology and the ways that you may help them, they can call you at what number?
603-606-1611.
And related to your website for further information?
AdvancedHealthNH.com.
And you have a wonderful blog on your site also that's
Yes.
very informative, as well as you show a number of the HealthView, our shows on there, which
Right.
are also very informative. So that's a
Yes.
great way to do that. And if any of the listening audience has any particular topics that they would like us to address, please contact us at info@ycdholistic.healing.com. So an endocrinologist is someone who specializes in the endocrine system and in hormones.
Correct.
And your qualifications in your studying is that you are a board-certified internal medicine physician as well as a specialist in endocrinology. This has been a very, very helpful discussion and I believe very informative for our listening audience. And as always, we want to make sure that our listening audience always takes the very best care that you possibly can of yourselves and utilize the HealthView to learn about how you can be more informed to make proactive decisions related to the best care that you can possibly have. And again, you can reach Dr. Ochamaya at
603-606-1611, AdvancedHealthNH.com.
We wish you a very healthy week and day and look forward to seeing you again very soon. And we thank you for being with us today. We totally enjoy being able to come into your homes and have you receive information that will help you.
Thank you.
The preceding